Yes, sir. Good morning, everyone. My topic is carcinoma oropharynx, clinical presentation, staging, and the role of HPV. So, coming to the introduction part, uh, yeah, the oropharyngeal squamous cell carcinoma, it is one of the few cancers increasing in incidence due to increased incidence for human papillomavirus infection. Most HPV infections they clear within the year and they don't result in malignancy. However, in the patients with persistent high risk HPV infection, there is significant risk of developing HPV related oropharyngeal cancer. Coming to the low risk and the high risk strains of HPV, the low risk strains include 6, 11, and the 53, and the most common among them is 53 strain. And the high risk strains of HPV are 16, 18, 31, 33, 52, and 52. Among them, the 16 and the 18 are the most common worldwide, causing responsible for the carcinoma uh, oropharyngeal. And the benign cutaneous manifestations which result from low risk HPV strains are warts, and in the oral cavity, there are the oral warts papillomas, mainly the mucosal manifestations. Then coming to the role of human papillomavirus, there are the two oncoproteins E6 and E7, which plays a very important role in the cycle of HPV. The E6 and E7 oncoproteins, they are going to inactivate the tumor suppressor proteins that is P53 and retinoblastoma respectively, which is necessary for the malignant behavior of these tumors. Usually the RB and the P53, they are the tumor suppressor proteins which are going to suppress the tumor. And in contrast to HPV negative squamous cell carcinoma, in which the TP53 is frequently deleted or mutated. This gene is rarely altered in HPV positive squamous cell carcinoma, and the P53 is eliminated by the action of E6 in HPV. P16 is a tumor suppressor protein, and its overexpression often represents unsuccessful attempts to stop cell division. Um, we can, sorry, um, in this diagram, we can have the we can see the role of P16 as a marker, how it is serving as a marker. In HPV, we have the two proteins E6 and the E7 oncoproteins. So E7 is going to inactivate the retinoblastoma protein and results in the activation of the E2 effector, which results in the cell cycle progression and thus related to the malignant behavior of the tumor, which results in the activation of P16 that represents the unsuccessful attempt to stop cell division, as I earlier told. Then coming to the CAP guidelines for the P16, the CAP guidelines, um, it is basically the oh yeah, according to the CAP guidelines, we have the standard cutoff for the P16 quantitative analysis. In this, we have the P16 immunohistochemistry positive analysis, in which there is a more than 70% nuclear and the cytoplasmic moderate to strong staining. And in P16 IHC negative, it should be less than 70% nuclear and the cytoplasmic moderate to strong staining. Uh, then coming to the anatomy, oropharynx. Coming to the oropharynx, it is a part of continuity of the pharynx, extending from plane of a superior surface of soft palate till the superior surface of hyoid bone. Then coming to the HPV mediated cancers, which usually arise in the lymphatic tissue of palatine and the lingual tonsil, but it may arise in any regions of oropharynx. And oropharyngeal cancers usually involve upper and mid jugular lymph nodes, and less commonly the submantle and the submandibular group of lymph nodes. The base of tongue cancers commonly manifest in a bilateral lymph nodes. And the most common site of distant metastasis for OPSS is lung followed by bone. Coming to the clinical presentation in OPSCC, first one is a tonsil. In oropharynx, we have the soft palate, tonsil, base of tongue, and the posterior pharyngeal wall. And I'm going to discuss the clinical presentation in each of this. Coming to the tonsil, tumor originate in the tonsil, which comprise around 23.1% of all the malignancies in this anatomical region, and the incidence rate is 8.4 per 10,000, and it the clinical presentation of tonsil is usually asymptomatic. Most common site of primary tumor in context of carcinoma of an origin, and if it is a most common site of primary tumor in context of CUP, then the presentation it is cervical lymphadenopathy. And as the tumors enlarge, they extend outside the tonsillar fossa, and direction it can be cranial to the soft palate, caudal to the tongue base, and posteriorly to the posterior pharyngeal wall, and anterior superiorly towards the retromolar trigone, and laterally to involve the pterygoids and the carotid sheath. If there is an involvement of the pterygoids, then it will result in a trismus. This is a clinical presentation of the carcinoma tonsil. Coming to the base of tongue, the tumors of base of tongue, they are apparently occult, only coming to light during the investigation of enlarged node. Local extension is typically towards and across the midline, as well as extension into the muscles of tongue, that is extrinsic and the intrinsic musculature. If the local extension it is greater, then more likely the patient present with the symptoms odynophagia, persistent pain, dysphagia, altered speech, and impaired tongue movements because of the involvement of muscles. Then flexible fiber optic endoscopy and bimanual digital palpation are necessary for the diagnosis for the base of the tongue tumors. Coming to the soft palate, majority of the soft palate tumors, the remaining one contributes to the OPSC. The tumors presented as a painful ulcerative lesion or with the involvement of retropharyngeal node. Tumors behave in an aggressive manner with poor outcomes. Coming to the posterior pharyngeal wall tumors, they present late with the symptoms of odynophagia, persistent sore throat, and referred otalgia. There is a space between the pharyngobasilar fascia and the prevertebral fascia, which often act as a barrier to deep thread. And if this space is involved, then there is a tumor fixation, which is a very poor prognostic sign. Coming to the presentation of the patients with oropharyngeal carcinoma, they present in various ways with symptoms related to primary tumor with or without enlarged node, which is usually painless and present at level 2 node. And with an enlarged node, usually painless in the absence of symptoms related to primary tumor. There is a carcinoma of unknown primary origin. Coming to the unknown primary cancer, patient presented with squamous cell carcinoma and the cervical node, and despite an extensive workup, site of origin may remain undetermined in 25 to 50% of patients, as quoted in Nag et al. Paper 2015. Well lateralized lesions spread to ipsilateral leg nodes, and lesions are near the midline. They spread to the both sides of neck, although the risk is higher to the site which is occupied by the bulk of the tumor. Likelihood of retropharyngeal adenopathy related to presence of clinically involved nodes and primary site, and that is particularly high for nasopharyngeal and oropharyngeal cancers. Then coming to the clinical examination for patients presenting with signs and symptoms of oropharynx cancer, thorough examination of head and neck should be undertaken. The skin of neck can be examined while the clinician is palpating the nodes, and the neck examination to be done thoroughly. Cutaneous lesions of discoid lupus presented with gingival inflammation. It should be seen during the oral examination. High resolution examination of entire nasopharynx, oropharynx, and hypopharynx should be done. Coming to the clinical examination, coming to the lymph nodes part. So the major lymph nodes of head and neck area should be palpated in the upright position. Coming to this is the preauricular lymph node, post-auricular lymph node. Then these are the level 1 group of lymph nodes, submantle and the submandibular group of lymph nodes. these are the level 2A group of lymph nodes, and these are the supraclavicular group of lymph nodes, uh, which should be palpated in the head and neck. This is the post or examination for the post-auricular lymph nodes. This is for the pre-auricular lymph nodes. Coming to the level 2 group of lymph nodes, this is the bidigital palpation of the level 2B group of lymph nodes, and this is the for the bimanual palpation for the level 2B. Coming to the submental and the submandibular group of lymph nodes, this examination is for the submental group of lymph nodes, and this is for the submandibular group of lymph nodes, and this is for the supraclavicular group of lymph nodes. Then coming to the oropharynx part, examination for the oropharynx. It comprised of palatine tonsil, soft palate, posterior third base of tongue, lingual tonsil, and posterior pharyngeal valve, as I already discussed. Uh, we have to place the mirror or tongue depressor on the dorsal surface on the posterior third of a tongue and depress formally. And the patient says which usually coordinate the soft palate and the uvula together so that we can visualize these structures well. And just to prevent the gagging, we can place the salt on the tongue for the better visualization of the structures. Coming to the posterior pharyngeal wall, the tissue appear very vascular but homogeneous, reddish to pink with normal areas of scattered lymph nodes. So this is the normal presentation. If there is any pathological involvement of posterior pharyngeal wall, then there should be erythema associated with the postnasal drip, and erythema and the purulent exudate associated with the pharyngitis. In this presentation, it's a normal one on which there is no erosions, no growth on the posterior pharyngeal wall. Then coming to the anterior and the posterior pillars of the tonsil, which should appear vascular and symmetrical. And atypical findings include lymphoid aggregates as found on the posterior pharyngeal wall, area of pale scarring. So this is the anterior, sorry. So, coming to the tonsillar part, this is the anterior tonsillar pillar. This is the posterior tonsillar pillar, in which in between there is a tonsil. So we can say in this present picture, uh, both of the anterior and the posterior tonsillar pillar, they are normal. And the pathological findings, it includes asymmetry, lesion of any kind, erythema associated with tenderness and exudates. And after a tonsillectomy, one may observe residual tonsil tissue or a regrowth of a lymph tissue in the area that suspects the carcinoma. And coming to the lesions of any kind over the soft palate and the uvula, loss of function or lack of symmetry during function, both of which may indicate compromised swallowing capability and a higher risk of aspiration of a food and oral fluids into the lung. Um, so we have to examine the abnormality in the color, shape, deviation, swelling, or any other lesion that suspect the carcinoma. In this picture, there is a enlargement of the uvula. Then palpation of the glossotonsillar sulcus, where palatine tonsil meets the posterior base of a tongue. Biopsy of the primary lesion, it can be performed under local anesthesia in clinics. Utilization of ultrasound imaging, focusing on biopsying the whole of lymph node, helps to decrease the rate of non-diagnostic biopsy. Core biopsy can be done, but it usually is reserved for the situations where FNA is non-diagnostic after various attempts. Then coming to the base of tongue lesions or tonsil lesions may require direct laryngoscopy under anesthesia. Triple panendoscopy to rule out the synchronous cancers. That includes laryngoscopy, nasopharyngoscopy, bronchoscopy, and esophagoscopy. Coming to the imaging part for the diagnosis, CT is often the first imaging study of choice with new neck mass. with new neck mass and suspected to adenopathy. MRI is the alternate cross-sectional modality employed for the initial staging, post-treatment evaluation, and the surveillance. PET-CT, it's being used with greater frequency for staging, treatment evaluation, and the surveillance, and in case of the contralateral node involvement and for the distant, to rule out the distant nodal metastasis. Then coming to the detection part for the HPV, the algorithm which we are having, it's the immuno IHC for P16 and the in situ hybridization, that is both DNA and RNA. We usually diagnose it with the P16 marker, which is a surrogate marker. And in situ hybridization, um, in DNA, ISH, we use this technique uses an antisense probe which binds to a complementary HPV DNA target present on the tumor cells. Determination of the integration status of HPV DNA by ISH has been a routine practice because of its cost effectiveness, but the effectiveness of this assay, it is limited because of its low sensitivity. Coming to the RNA part, ISH. RNA ISH uses probes that are complementary to the E6 and E7 mRNA, as we saw in the life cycle of HPV. So this is the gold standard for HPV detection in tumor tissue for RNA ISH. At present, HPV mRNA, it has a great advantage compared to the DNA ISH because of its ability to detect the presence of transcriptionally active human papilloma virus, which indicates the existence of HPV-related oncogenesis. And it was demonstrated to have the higher sensitivity than the DNA ISH. This is the histopathological slide for the HPV negative and the HPV positive. In HPV negative, there is a keratinization which is present, and in HPV positive, there is no such keratinization, and there is a basiloid pattern in HPV positive, which is usually absent in the HPV negative. And then, as I discussed earlier also, for P16 as a surrogate marker, there are the CAP guidelines for the same. If the P16 actually it's positive, it should be more than 70% nuclear and a cytoplasmic moderate to strong staining. Then coming to the uh, some differentiation points in between the two, HPV positive and HPV negative. In HPV positive, multiple enlarged cervical cystic nodes are there. In HPV negative, the presentation is usually the large primary tumors in head and neck, and there is a lower tumor burden in cervical node. There is an incidental discovery of painless cervical node in HPV positive, while in HPV negative, the primary tumors incidentally detected following inspection of oral cavity and oropharynx. In HPV negative OPSC, their clinical manifestation is the tumor along with the referred otalgia and the dysphagia, while in HPV positive, it is the node presentation. And the etiological agent in HPV positive is HPV 16 and 18, which are the most common and the highest strain, and transmitted, and it is a sexually transmitted through the STD. And the etiology for HPV negative is tobacco and alcohol. And the main mechanism for HPV positive OPSC is the integration of HPV in the host genome and the action of the HPV E6 and E7 proteins, which play a very vital role in the life cycle. Else in HPV negative, there is alteration in the tumor suppressor or the signaling pathway. The prognosis is better in HPV positive as compared to the HPV negative, and they are more sensitive to the radiotherapy as compared to the HPV negative. Then coming to the etiology of HPV negative, so we can see the carcinogenic agents, tobacco, alcohol, areca nut. After the exposure to these carcinogens, there is activation of the pathways which lead to the DNA damage and the inability to repair the DNA results in the head HNSCC and HPV negative. Coming to the staging part of OPSC, this is the for P16 positive and P16 negative. This is the T. In P16 positive, we have T0 to T4, and in P16 negative, we have TX to T4. Then coming to the clinical staging for both P16 and the P16 negative. Then coming to the pathological for both. And this is the metastasis M0 and M1 for both P16 and P16 positive and negative. Then after having a comparison for both positive and the negative, we have the different stage groups for both positive and the negative. Why we are having this staging group? It is for the prognosis purpose. The prognosis, it is better in HPV positive as compared to the HPV negative. And in the landmark study by Angetol in 2010, uh, there was a retrospectively analyzation of outcomes of patients with stage 3 and 4 OPSC treated with CRT in RTOG 0110-129 study by HPV status. There was a 3-year overall survival rate, and it was 82.4% in HPV positive and 57.1% in HPV negative patients. And in this study, there were the two groups. Among the two groups, the patients were randomly divided, and in one group, there was an accelerated fractionation radiotherapy was given, and then in another group, the standard fractionation radiotherapy was given, with simultaneously administration of the cisplatin also. Then coming to the overall survival, and this is the Kaplan-Meier curve, in which there is a comparison of the overall survival rate. This is the high risk, in which the overall survival rate was 93.5%, and in the intermediate group it was 67%, and in the high risk group it was 41.6%. Then coming to the prevention part for the HPV. Primary prevention, it involves interventions to reduce the incidence of disease in the first place. When it is considered as a target for primary prevention, most cases of HNSCC would indeed be preventable with successful global elimination of tobacco use and implementation of HPV vaccine. Immunotherapy against HPV-associated tumors. In 2006, the first vaccine, quadrivalent vaccine, was approved in US for the prevention of both cervical and the genital warts. Quadrivalent vaccine targets HPV genotype 6, 11, 16, 18, 4 strains, which are responsible for approximately 66% of cervical cancers and 90% of genital warts. And this vaccine cover for both females and males. Females aged 9 to 26 years, and same is for males. Um, Quadrivalent vaccine says strong prevention rate, more than 90%. Coming to the bivalent vaccine, which targets the HPV strain 16 and 18, and that was approved in 2007. And these strains causes around 70% of cervical cancers. Approved by FDA in 2009, and there is a 93% reduction in prevalence of HPV. That is for the strain 16 and 18. Then coming to the Gardasil 9 vaccine, which targets for the males and females both aged 9 to 45 years. And it is potential to protect against 90% of the cervical cancers. Thank you.
Thank you, Dr. Manika, for the nice presentation. So, are there any questions? So, basically, oropharyngeal cancers, we all know that it used to be a very neglected part of surgical oncology training earlier. Why? Because most of them think that these patients will go to radiation oncology department and they were primarily treated with radiation or chemoradiation alone. There was very little scope of surgery at that point of time. But now with the advent of robotic surgery, the surgeons are also started dealing with the oropharyngeal cancers like tonsil, base tongue, pharyngeal wall tumors. These can be taken up by robotic surgery. So it's a very important topic. Unfortunately, we do not know much about the anatomy. We are not very clear about the anatomy part, as people don't read it quite often. There are a few questions. You told about the symptoms. What is the commonest symptom when you have any tumor in the base of tongue? What is the commonest symptom? Manika, please tell.
Sir, the commonest symptom in the base of tongue, it is, matlab, we have to basically palpate. Matlab, there is no presentation for the base of.
I have asked for symptom. Palpation is a sign.
Yes, sir.
Stick to basics. I have asked what is the commonest symptom for any tumor in base of tongue. Very simple question. Have you seen patients of base of tongue?
Yes, sir. Sir, it is.
What do they say?
Yes, sir. The presentation for base of tongue, it is odynophagia and dysphagia and odynophagia.
Dysphagia and odynophagia are the late symptoms. There is a typical voice of these patients. What is the typical voice? How do they speak? Have you heard of hot potato voice?
Yes, sir.
What is that?
So the hot potato voice, it is usually that muffled voice.
Right. It's as if somebody put a hot potato in your mouth
Yes,
and
sir.
the person speaking like that. This is the first and the commonest symptom of base tongue tumors.
Yes, sir.
It's a classical symptom. It's written in the books also.
Okay.
So that should we should know. And what is bimanual digital palpation you set for base tongue tumors? How do you palpate base tongue tumors bimanually? You said you will do a bimanual physical digital palpation of base tongue tumor. Where will the other hand?
Sir, for the bimanual digital palpation, uh, we placed one tongue over the base of tongue and the.
You have only
Matlab for
told
the.
us. You have
Yes,
only
sir.
told us.
Sorry.
How do you demonstrate this physical sign? Because in the examination these small things will be asked.
Yes,
Big
sir.
things will not be asked. You'll be asked only these things, and you said you will do a bimanual examination of base tongue tumor, isn't it?
So, sir, for the bimanual base of tongue tumors, first of all, we have to place the like pressurize the tongue with a gauze so that it should be outside as
And
much
then
as possible.
your one hand will be with the gauze itself. You
No,
will do a bimanual.
it's by roller gauze which I
Okay.
placed over the like in the front of tongue so that it can be pushed maximum outside जितना भी हो सकता है. And then we can palpate it.
With one finger or two fingers.
So it's with like one finger over the like base of tongue and the another finger is like nature downwards.
And another finger is where?
It's
Just check in
it's
the book.
the like in
How
the
it is
base
done.
of
How
tongue
it is done.
downwards.
Okay. And what is the commonest tumor of the soft palate? I'm preparing you for the exams.
Yes, sir.
So, what is the commonest tumor of the soft palate?
So for the so it should be papilloma.
Malignant tumor. Difficult question again. Oh, okay. It's the commonest tumor of soft palate is minor salivary gland tumors. They're the commonest tumors. Okay. So, how will you do a lymph node examination in head neck patient? Where will you stand and where will the patient be there?
So for the lymph node, for the lymph node examination in head and neck cancer patients, um, it should be in the upright position, and I will
Okay,
stand behind the patient for the examination of lymph nodes.
good. That is the most important thing.
Yes,
If you
sir.
start examining these patients from front,
Yes, sir.
then the examiner will object. Okay. And the other thing you have told already that the HPV positive patients, they've got bulky nodes and smaller primary. Whereas non-HPV positive patients, there's a bigger primary and smaller nodes.
Yes, sir.
What is the role of indirect laryngoscopy in these patients? Now, it is being done or not?
Oh,
Ideal. The mirror examination.
so the mirror examination, it is not in use much. Matlab, we prefer to have the uh, direct laryngoscopy rather than the indirect measures.
That is true when you are in a big institute, when you are in your clinic.
Hmm.
All of you know how to do indirect laryngoscopy? What all you can see on the mirror when you do an indirect laryngoscopy? Have you done it?
Uh, yes, sir. मतलब
एमबीबीएस में तो किया होगा ना ईएनटी में.
yes, sir, I did it.
So what all you see in the mirror when you do an indirect laryngoscopy?
In the indirect laryngoscopy, with the aid of mirror, uh, the base of tongue
Yes.
and the base of tongue posterior one third and
What
soft palate.
what is base of tongue posterior one third?
So it
Either
is
you say
the same thing,
base of
same
tongue
thing.
or you say posterior one third of tongue. Both are the
Posterior-
same thing. No?
Yeah, so it is the same
What
thing.
is the boundary of base of tongue and oral tongue? How do you know from where base tongue starts?
So the circumvallate papillae, it is going
Circumvallate
to
papilla.
differentiate the anterior two third and posterior one third of the tongue.
Right. Okay.
Yes, sir. And the structures which are visualized in the oropharynx vallicular base of tongue and in um, piriform fossa and the epiglottis.
You can see on indirect laryngoscopy.
Sir, epiglottis,
Yes, epiglottis.
lingual aspect of epiglottis,
Okay. And
and vallicular, and then glossoepiglottic folds with the aid of mirror.
and you don't see chords. You
Mm.
cannot see vocal cords.
Sir, it's the false vocal cords.
Whatever. Can you see vocal cords or not? False vocal cords.
Sir, I will see false vocal cords, false in the true both.
A head neck surgeon must know all these things.
Yes,
What
sir.
they're going to see in indirect laryngoscopy. So all these questions are very simple questions, but they are tricky questions.
Yes, sir.
Hmm. Dr. Karan, anything you want to ask or add or comment?
Sure, sir. Good morning.
Morning.
So, Dr. Manika, when Dr. Rajiv sir was asking you for bimanual palpation of the base of tongue, what's the main thing you want to see in a bimanual palpation? That has relevance clinically and also in your treatment planning.
Um, so the main thing is about the occult presentation in the base of tongue.
Manika, it's a growth on the base of tongue. If
Yes,
you're
sir.
doing a bimanual palpation, what do you want to see? So basically, you want to see if the hyoid is involved by the primary or not. So your other hand is outside on the neck and you hold the hyoid and try to move the growth and the hyoid. If there is no movement between the growth and hyoid, then there is clinically hyoid involvement, which has implications in choosing the treatment for this patient.
Okay, sir.
Now, coming to the question of indirect laryngoscopy versus a fiber optic laryngoscopy or a 90-degree Hopkins, what are the areas which cannot be seen on indirect laryngoscopy? This is a basic MSc question.
Sir, the areas, it is the piriform fossa, which is not visualized in indirect laryngoscopy. And there is a like post-cricoid area, which is not visualized.
Okay. So the ventricles cannot be seen. Sometimes the
Yes, sir.
anterior commission cannot be seen. Sometimes the laryngeal surface of the inferior laryngeal
Epiglottis.
surface of epiglottis would not be seen. So these are the hidden areas of larynx which you do not see on ideal. So that's why a proper fiber optic laryngoscopy or a Hopkins is required if you are doing a triple endoscopy to see for a second primary.
Yes, sir.
And every head and neck case will need a detailed examination of all parts of the head and neck. One, to see if there is any second primary or not. So it can be synchronous, it can be metachronous. So you have to do a complete head and neck examination for every patient.
Yes, sir.
Just based on the clinico-radiological examination of a patient who presents to you with a growth on the base of tongue and a lymph node, can
Yes,
you
sir.
make a guess, will that patient be HPV positive or negative? Are there any pointers towards HPV positive in tumors
Yes, sir.
on clinical radiological investigations?
Sir, clinically, for the base of tongue tumors, there is a bilateral presentation of the nodes in HPV positive.
HPV negative will not present with bilateral lymph nodes if it's a midline growth.
Mm, no. First, it will present with the tumor. The node presentation, it will be later on as compared to the HPV positive.
Is that the rule, Manika?
No, it's not the rule.
Then so what are the radiological features of HPV positive lymphadenopathy in simple terms?
In HPV positive OPSCC, there are the
You, Manika, use full forms. There is nothing known as OPSCC on your examination.
yes, sir. In human papilloma virus positive oropharyngeal squamous cell carcinoma, the presentation of nodes are multiple and the cystic nodes.
So yes, they are enlarged, they are cystic, but they do not have evidence of extranodal extension on their radiology. Whereas HPV negative lymphadenopathy can be multiple, small, necrotic with evidence of extranodal extension on radiology. So that can give you a clue that this might be an HPV positive related tumor.
Yes, sir.
In clinical examination, what all will you do when you are examining a tonsil?
So for clinical examination of in the tonsil, I will see the both of the pillars of the tonsil, anterior and the tonsil, posterior pillar of the tonsil, and then the
Stop moving
extension.
the slides, Monica.
Okay, then extension of the tumor for outside the that tonsillar crypt area, whether there is a extension to the cranially, caudally, cranially and caudally extension to the posterior pharyngeal and to the retromolar trigone area also, and to the carotid and the involvement of the muscles.
Why is this relevant?
So that there should be proper staging for the tonsillar tumors for the tonsil and for the proper management.
Could you elaborate on the management part?
Mm. Sir, if there is a extension and in stage 3 and stage 4 tumors for the tonsil part, um, the management is different. We are going to have the TORS, and
What is TORS? I told you not to use short forms, Manika.
yes, so transoral robotic surgery for
You will
the.
for a stage 3, stage 4 tumor.
It's not for the stage 3 and stage 4.
Chalo, treatment wasn't a part of your presentation, so
Yes,
just
sir.
we let it go. You talked about staging of HPV positive and HPV negative tumors being a little different. Could you
Yes, sir.
elaborate more on that?
Yes, sir. Just wait. Sir, in the staging part, we have the positive and the negative one. In HPV positive, like for example, if we are taking the T stage T3 and the N0, 1, 2 and M is M0 and the stage group is 2 in HPV positive. While for the same, if the T1 is T3 and N1 is N1, and in this the stage group is 3 as compared to the stage group which was 2 in HPV positive. So it is having a good prognosis in HPV positive, and it lead to the de-intensification of the treatment for HPV positive while we are observing the T and M staging for the same stage.
Manika, you talked about de-intensification. Do you know about any trial which has talked about de-intensification of HPV
Sir,
positive tumors?
there is a landmark study by Engdahl in
Ang
2000.
et al. Ang et al. Did not talk about de-intensification of treatment. There is nothing about de-intensification of treatment in the RTOG 0125 published in NEGM 2010. They just differentiated, and that too a retrospective analysis where they differentiated oropharyngeal cancers into HPV positive and negative and further subdivided them based on the smoking number of pack years. They never talked about de-intensification. It's a landmark study which every head and neck fellow should know, and you should know the study properly, what they did, what they did not, and what was the conclusions. So Kianang did not talk about de-intensification. Do not randomly start speaking words where you do not know the meanings of them.
Okay, sir.
Okay.
Yes, sir.
So do you know about any literature which talks about difference in staging between HPV positive and HPV negative? Was this difference present in the 7th edition AGCC?
So no, sir. This difference was not there in AGCC 7.
So which evidences made 8th edition AGCC differentiate between HPV positive and negative tumors?
Sir, evidence in view of?
Evidence to support that HPV positive patients do better than HPV negative, and there was a need to separate the staging criteria based on HPV status.
Uh, Sir, there is a
Kindly,
there is
kindly, Manika,
yes,
kindly
yes,
go
sir.
through the references which are behind the HPV positive tumors classification in the AGCC man. You will get to know what was the evidence on which this differentiation has been based. Okay.
Yes, sir.
So any other questions from your side? Because I can see none in the chat box.
No, I think that is enough. And you should read more about this. You will prepare a little more. Hmm.
So if there are no other questions, can we close the session?
Sure. Dr. Navneet?
Dr. Navneet, can we close the session?
Okay. Anything in the chat box, trainees, if you have any questions? Sir, can you keep check the chat box, sir?
Okay, so they just want to know which are the hidden areas in indirect laryngoscopy. So the ventricles cannot be seen, the vestibule cannot be seen. Sometimes the laryngeal surface of epiglottis inferior 1/3 cannot be seen. Sometimes the anterior commissure is not very well visualized. The PFS might not be seen. So there are about 7-8 areas which of the larynx which are not seen on IDL. That have been the advantage of fiber optic laryngoscopy. I see no other question in the chat box.
Dr. Rajiv, any concluding remarks, sir?
Yes. So oropharynx had been a very neglected area for surgeons for a long period of time. Now it's time, as I already told, with the advent of robotic surgery, the surgeons should start taking interest in this part also. And it requires little more study of this area. And I hope everyone will do that. Thank you.
Yeah, there is one more comment from Dr. Ishu Ahmed.
Thank you, Dr. Karan, Dr. Navneet.
Sir,
Thank you, sir.
there is one more question from Dr.
Yeah.
Ishu Ahmed.
Yeah, Navneet, I've replied it on the chat box.
Okay, sir. Thank you. Thank you very much, trainees and faculty members, for joining the session.